I'd like to thank the organizers for the opportunity to speak to you today, and I want to apologize to you all for not being able to be with you in person because of personal reasons. I'm sure you've had a very good conference and will continue to do so. These are my disclosures. I want to talk to you today about the immunoglobulin supply-demand landscape, and I want to immediately introduce some terminology which I shall be using. I define here the demand of immunoglobulin, which continues to rise around the world, and this is because of increased capacity for diagnosis, the increased survival in the key patient demographics as the patients are treated and they grow in size. Dosage is based upon body weight, and survival increases the number and the total consumption of the immunoglobulin. At the same time, we are seeing a widening of the evidence base as new diseases are trialed and are included or not. And of course, we have, thanks to advocacy by both patients and treaters, increased access to care. But we need to differentiate the usage of immunoglobulin from its sufficiency. Usage is a snapshot of what is happening in a particular landscape. Sufficiency is another issue. And as an example of this, I will simply show the never-ending example of the Czech Republic, where vast amounts of plasma are collected for the manufacture of plasma-derived medicinal products. However, this is not being done within the Czech Republic for the Czech populations of patients, but is being sold to commercial companies, which then extract the various products which are available from plasma and put them on the open market. Suffice it to say that the amount of plasma which is collected in the Czech Republic is able to generate 308 grams of immunoglobulin per 1,000 population for that country, whereas of course the actual usage is only 60 grams. And this is due to issues of access primarily for the local population. As you may know, I come from Australia, where we have one of the highest per capita uses of immunoglobulin in the world. You can see from this latest snapshot of data from the Australian authorities that the current consumption of 340 grams per 1,000 population is noted in Australia. I have to emphasize that this usage is very strongly controlled. It is not easy to be able to prescribe publicly subsidized immunoglobulin in Australia, and all the indications which you see here are based on level 1 evidence. I point out that the highest indications include secondary immune deficiency as well as CIDP, and I shall be speaking about these later on. I want to introduce the concept of latent therapeutic demand. As I have indicated, usage approaches sufficiency only when the supply approaches the potential clinical demand within a particular environment, and we define latent therapeutic demand as the underlying demand that represents how physicians would prescribe treatment and how patients would comply with the prescribed treatment if ample supplies were available and affordable, and access to therapy was unencumbered by issues other than evidence-based clinical need, such as financial constraints. We may therefore consider latent therapeutic demand as being the justifiable demand, the real underlying demand for immunoglobulin in this instance. What I'm going to describe in relation to this aspect is basically summarizing the findings of 3 publications, which you can see here, which I refer you to within the literature. If you look under latent therapeutic demand and immunoglobulin in PubMed, you will find these publications, and I will summarize many of their findings in this talk. This is the so-called influence diagram, which basically shows us the variables which are synthesized in relation to then coming up with a figure for final therapeutic demand. And as you can see, the key variables here are around the prevalence of the relevant disease, as well as the actual amount of immunoglobulin which is administered basically through dosage type patterns. This is the key output from this kind of model. The model itself is generated through statistical decision analysis, and we need to have decision analysis because around many of the parameters which I have outlined in the previous slide, we have a high level of uncertainty. This uncertainty therefore needs to be modeled on the basis of statistics, and one of the key outputs from such a model is the so-called tornado diagram. These kinds of models can be done using specially purchased statistical packages, which are quite expensive, but skilled people in this field can also do these using standard type packages such as Microsoft Excel. The tornado diagram shows us two things. First of all, it shows us the hierarchy of demand. It shows us that in this instance, showing the extraction of the data for primary immune deficiency disorders in the United States, treatment frequency is the highest level of variable. It shows huge variability, and the second level is shown by the prevalence, and this is quite important to understand. In the table adjacent to the prevalence bar, you can see the various inputs which went into generating the prevalence estimate, and you can see that there are several publications, each with their own estimate of prevalence of the primary immune deficiency disorders, and therefore we are synthesizing these various inputs into one estimate of prevalence, which is shown on the tornado diagram. This is simply similar tornado diagrams for the relevant diseases in the autoimmune neuropathies. These were also separately modeled in a similar model to the primary immune deficiencies, and you can see that dosage and prevalence are also extremely important in the hierarchy of weights which are attributed by the model. Now, which research questions can we extract from interrogating such models? We need to focus on the key contributors to the latent therapeutic demand estimate, which, as I have indicated, include the disease prevalence and the treatment dosage. This is obviously very clear from the models. Of great importance in terms of posing some research questions is the issue of diagnostic criteria. This slide summarizes data from two separate studies, one from New Zealand and one from Finland, extracting the diagnosis of, in this instance, CVID, the most common primary immune deficiency, using criteria from three separate sources. The criteria developed by the New Zealand group headed by Rowan Ameratunga, the criteria defined by the ESID, as well as criteria defined by this other group icon over here. And you can see quite interesting data from this slide, because you can see that for the New Zealand studies, this New Zealand study showed that the criteria defined by Amaratunga gave a much higher diagnostic rate, a much higher prevalence of CVID than the other two criteria. We attribute this because of diagnostic capacity within the New Zealand environment, which influences greatly the criteria, the definitions posed by ESID and ICON, in the sense of requiring certain parameters such as IgM and IgA to be also measured, whereas this is not mandatory in the Amaratunga criteria. Another important difference is the inclusion by Amaratunga's group of the inclusion of probable and possible CVID as well as definite. You can see that this difference does not really show up all that strongly in the study from Finland, and this is because diagnostic capacity appears to be more prevalent, appears to be more available in the Finnish environment, so that the prevalences, the diagnosis of the disease using all three criteria approaches similarity. This is interesting data for prevalence in different countries, and I just point out in relation to the left-hand part of the slide the differences between the Scandinavian countries, and Finland has a substantially higher prevalence of CVID. This was well described in a publication some years ago, and it reflects the genetic isolation and potential founder effects in the Finnish patient population. A very interesting example of the need to study particular demographics individually. Interestingly, in relation to dosage as well, we see differences between the United States and Europe, and this is summarized in this slide comparing the US IDNet data with the ECID registry data, and you can see that for CVID there is always a higher dosage observed in relation to between the US and the European environments. The Americans are always using more. This is not as visible within the environment for X-linked agammaglobulinemia. It is possible that this difference is because of a different therapeutic philosophy between the United States and Europe, influenced by the kind of analysis which you can see on the right-hand side of this slide, whereby in America increased the dosage as perceived through a meta-analysis by Jordan Orange some years ago is perceived to result in better clinical outcomes, whereas the European data, as demonstrated by Isabella Quinti in Italy, shows a plateauing of therapeutic effect at a certain dosage, which does not therefore improve the clinical picture if the dosage is increased. These are important insights. There is also the question of how does one dose? Does one dose purely through following blindly the relevant guidelines, or does one try to practice personalized medicine in this aspect? We can see here a study, again from Quinti's group in Rome, showing that by personalizing the dosage to patients through the algorithm, which you can see on the left-hand side, dosage at 2 weeks in intervals showed a much higher level in the trough measurement of immunoglobulin than the standard dosage at wider intervals, at the same time as leading to improved clinical results and not increasing, importantly, the overall dosage and therefore the costs. Just a word on the same aspects in relation to CIDP. We can see from this slide that CIDP in Australia, the prevalence is quite remarkably varying depending on the criteria. The number of patients prescribed immunoglobulin through the system, which I outlined before in relation to this snapshot of data, which is the latest one that we have, is about 60% higher than the prevalence estimate using the European Foundation for Neurological and Peripheral Nervous Syndromes criteria. This is quite an important difference because it is the number of patients prescribed, obviously, which are resulting or impacting on the overall usage of the immunoglobulin. And the question is, what is influencing the first line in this slide, given that the criteria for actual prescription are very similar to the EFNS criteria. These are issues which are unresolved but are under review. Again, using an individualized versus standardized protocol for CIDP, we can see that we can achieve differences in real-time consumption for this disease as compared to when using guideline-driven protocols, whether they are using standardized dosing weights or the actual recorded weight. And again, clinical outcomes are similar. These are, as I said before, for PID, extremely important findings, and we must attempt to introduce these kinds of studies into mainstream real-time practice. As a result of the models which I have described for LTD, these are the actual latent therapeutic demand levels in the United States population. And you can see that the most important indication in these studies was actually CIDP, followed by CVID. In these studies, so far, we have not utilized the modeling for the other aspect of immunoglobulin usage, which I will now discuss. And this is the question of secondary immune deficiency. As you know, about 5 years ago, the European Medicines Agency amended its core SPC guideline for intravenous immune globulin to incorporate these guidelines on secondary immune deficiency. This obviously had a substantial effect on the clinical usage of the immunoglobulin in this group of diseases, because now clinicians could adhere to a specific label approved by the European Medicines Agency. This is a list of the various secondary immune deficiencies in terms of the hematological cancers, which result in secondary hypogammaglobulinemia and therefore in the usage of immunoglobulin to treat these diseases. Keep these in mind. Look at the percentages of the disease, the relative percentages within the diseases, which actually result in hypogammaglobulinemia. It is by no means a universal phenomenon and needs to be assessed for each individual patient. It is important to note, as shown in this French study from some years ago, that the level of compliance with EMA recommendations for receiving immunoglobulin in secondary immune deficiency is by no means universal, and you can see that there are considerable percentages of patient demographics in which the compliance varies from that defined by the EMA core SPC. And you can see as well a significant variation in practice between countries, both within Europe and across the Atlantic, in the way in which immunoglobulin and antibiotics are utilized for treating secondary immune deficiency in these hematological malignancies. You can see a significant variation across these countries within separate countries in Europe as well as in North America. And the question obviously arises, are these differences, which are quite substantial, having an effect on actual clinical outcomes? This shows something which is very similar, and I shall just gloss over it. Of quite great importance in relation to secondary immune deficiency, we have the issue of dosage duration, and when will dosage and administration of immunoglobulin cease in relation to secondary immunodeficiency from hematological cancer. This study from Australia very recently shows that the actual level of evidence in relation to duration of immunoglobulin replacement therapy as well as cessation rules is very low. There is very little evidence on how we operate in relation to the duration and the cessation of immunoglobulin. And this is shown as well in this interesting study in the United Kingdom, in which cessation of immunoglobulin replacement therapy was accompanied by still high levels of immunoglobulin, of IgG, in the patients 6 months after actual cessation. So this is actually an important example of basically studying and monitoring patients to show that we can actually seize immunoglobulin therapy and maintain the same levels of outcomes. So which research questions again ensue from assessing this secondary immune deficiency landscape in relation to immunoglobulin? We need to generate outcome measures from the different prophylactic regimes, focusing, of course, on the use of immunoglobulin. We need to assess when do we cease therapy, and this all leads us to the need for randomized clinical trials, comparing standard practice with potentially new interventions. And I would view the European Hematology Association, which has had a relationship also to the supply project, to be a potential champion of such very much needed clinical trials. And if I can come now to my final slide, I summarize that. We need to analyze and compare practice. We need to define and measure outcomes, and we need to design and conduct studies. But I frequently hear that data for the immunoglobulin use and demand is very hard to get, and it's difficult to approach this landscape. But I want to round off with some words from the man that you can see over there, the late President John F. Kennedy, who, in one of his famous speeches in relation to sending a man on the moon, said that we choose to do these things not because they are easy, but because they are hard, because that goal will serve to organize and measure the best of our energies and skills, because that is a challenge which we are willing to accept, one we are unwilling to postpone, and one we intend to win. I think this is very much applicable to our issues in relation to this question, and I thank you very much today for your attention.